Thank you, Jack. This is just going to be a rapid run through of just my own reflections, and then Sarah will do the same on her own personal reflections of the report for 2022. You can all read it for yourself, of course. No conflicts of interest, apart from that I co-chair the registry. This is probably the most important slide. So everything that I show you, and also what Sarah shows you, you have access to all those slides. So every year when we produce the report, we now also produce a PowerPoint set of slides that you can go to the Hip Fracture Registry website and download. We are really keen for you to use the data. It is your data. And it is set up in a way that you can move the arrows, so you can move the arrows on the performance slides to your own hospital and add some comments as to whether you think you're doing well, whether you think that's an area where you need to improve. So that's gold. That PowerPoint set is well worth downloading. Participation, so it's always good to know who is and isn't contributing. We are nearly there. In Australia, New Zealand, all 22 public hospitals are contributing or signed up and contributing data. WA, 6 hospitals, including a private hospital. Queensland, all 16 hospitals, public hospitals, and 2 private. New South Wales, 36 out of 37 hospitals have approval to enter data. ACT are pretty near there in terms of being able to enter data. Tasmania, all 3 hospitals, South Australia, all 5, and Victoria, we're still got a little bit of a way to go with Victoria, but it'll happen. In terms of the report, so we still elect to report against the clinical care standards. That's what we always set out to do, was have the clinical care standards and then report against them. So those usual ones: care at presentation, how well we manage pain, do we have an orthogeriatric model of care, time to surgery, up and walking, and then trying to prevent the next fracture. So that's the snapshot for 2021. So this 2022 reports on 2021. And actually our performance is reasonable. So green is where we're seeing improvement. Blue, there hasn't been much change. And fortunately, there's no red, which would be indicative of going backwards in terms of performance. We're getting better at assessing cognition prior to surgery. We're getting better at nerve blocks. 92% of patients will get a nerve block now across Australia and New Zealand. That's a substantial improvement from when we started a number of years ago. We're not necessarily improving yet in the documentation of pain, but we're certainly doing better in terms of administering nerve blocks. Most patients get seen by an orthogeriatrician. Our time to surgery, 82% of surgery within 48 hours. There's probably still some room for that figure to improve again. We've already highlighted the issue with offering people mobilisation versus their bum actually leaving the bed, and we need to improve in terms of the percentage of people who actually get up and start that process of mobilisation after surgery. And even though it's got a green dot, I remain embarrassed that 30% of patients are leaving hospital on treatment for osteoporosis. That still is not good enough. This is the first year we have reported on reason for not having surgery. So we know a very small number, maybe 3-4% maximum, don't have surgery. But they are an important group of individuals that we need to understand why they haven't had surgery and whether that decision ultimately is the right decision for those individuals. So the vast majority of people across Australia and New Zealand who don't undergo surgery are patients who are thought to be palliative, who are likely to die within a few days. What we don't know at this point in time is how accurate that is, and are we not operating and leaving people in pain for weeks upon weeks? So I think that's an area where we do need to look and make sure that we're delivering appropriate care. Most surgeons are very comfortable at acknowledging that sometimes the surgical procedure they undertake is a palliative procedure to alleviate pain and to facilitate management of pain at the end of life. Quality statement 2, very much around management of pain, which from a patient perspective is something that really does matter to them. So like I said, we're doing really well when it comes to nerve blocks. But I think for every registry, we have to keep pushing the boundaries. And actually what you're starting to see now, this is a New Zealand paramedic, is actually the paramedics starting to administer the nerve blocks. So when we're achieving nearly at 100% for nerve blocks in the emergency department in the hospital, it's time to move on to the next challenge. The next challenge is actually when you're moving these people around the most, which is in and out of an ambulance and into the emergency department and into the x-ray department, perhaps if we put that nerve block in earlier. So it's good to think how we evolve over time. Time to surgery, again, 82% of patients are getting surgery within 48 hours. I would argue that that time needs to be reduced. In the UK, it's 36 hours. There's no reason for it to be any different, really, in this country. And theatre availability continues to be the biggest challenge, 30% of the delays. So of that relatively small number that are delayed, 30% are still around theatre availability. Medically unfit, 24% of them. Maybe we could be better at getting people medically ready quicker, or maybe we're delaying unnecessarily, saying they're medically unfit. And my last slide is a challenge really just in terms of surgical procedure. So these are the displaced intracapsular fractures, and the vast majority of these patients will undergo arthroplasty. What we're seeing in this country, rightly or wrongly, is more patients being offered a total hip replacement. I don't know if that's a good thing or a bad thing. We do know that, I think Xavier's here already, so there's a latest update from Cochrane in terms of what treatments we should be thinking about for these sorts of fractures. And for many of these people, a hemiarthroplasty serves them well, and there's probably no requirement for them to have a total hip replacement. And when we're talking about arthroplasty as well, when you look at the White study, we're very definitely talking about a cemented procedure. So I think there's quite a bit of variability across the hospitals in Australia and New Zealand in terms of who's being offered a total hip replacement. I'm not making a judgment as to whether that number is correct or not, but I think we need to start having that conversation about what is the right number and are we offering the right people the right procedure. I'll hand over to Sarah.
Thanks, Jacqui. So, does that go back? So as a geriatrician, I'm, as you might imagine, interested in the orthogeriatric models of care. And you can see that, yes, the majority of patients do get seen by a geriatrician, but there's a handful of patients that don't. So in New Zealand, we've been gradually creeping upwards. Australia has been pretty much the same. I think Australia have been impacted more in New Zealand by COVID. So the facility audit showed that 42% of hospitals reported a negative impact, and we've already heard that wards were sort of repurposed and staff were reallocated. What I wanted to do, though, is draw your attention to these other groups of patients, of hospitals. So in the bottom third of the graph. So in New Zealand, so 9 of our 22 sites, less than 60% of patients are seen by a geriatrician. It's less of an issue in Australia, but there's still 13 sites where not particularly many patients are being seen by a geriatrician. We've been collecting, since the registry started, when geriatricians see a patient. And so this year we decided to actually look at that and report on time to geriatric assessment. In New Zealand there's quite a spread. So although 85% of patients are being seen by a geriatrician, the diamonds, so the red diamonds are median and the blue bar is average. So on average, patients are being seen at day 3. And so a number of sites aren't seeing patients until much later in their stay. And as you can imagine, there's probably quite a different focus seeing patients day 1 as there is day 6 or 7. With those patients probably being much more reactive rather than getting in early and trying to do delirium prevention. The picture in Australia is a bit different, so I think the processes in Australia have got themselves organised and well resourced so that patients are being seen on average within 2 days. So this information I've kind of been aware about for a while, but I've realised now how fortunate I've been to work in hospitals that have quite comprehensive services, and that there are many sites that are still struggling to find the workforce or support from management to develop these services. The registry, though, is a really powerful tool to take to managers to show that you might be down the bottom of a graph. And I certainly know in New Zealand, for example, Hawke's Bay, which were down the bottom of that previous graph in the process of developing an orthogeriatric service. So slowly but surely we are winning that game and getting more geriatricians involved. One of my major frustrations is the, at times, lack of cognitive assessment for any older person that comes into hospital. So junior doctors are very good at listening to the heart and their lungs, but nobody takes a moment to see if the person's brain is functioning. And obviously for hip fracture care, we place quite a lot of emphasis on knowing what somebody's cognition is like before their operation, because there are a number of different things that you will do for patients, and looking at what their assessment is following surgery and whether they have delirium or not. So the blue line is that you've had your cognition assessed and it's normal. The green, it's been assessed and it's abnormal. So it's really that blue, that light blue that we're interested in, which is slowly decreasing. But in New Zealand, we've got quite a lot of work to do. So we're not doing this for half of our patients. In Australia, the quarter of patients. And a similar picture and pattern for assessment of delirium. So things are improving, but we've clearly got a way to go. And what I would encourage sites is that if you're in the sort of bottom part of the graph, identify a hospital that's in the top part, because these are sites that have got their systems in place, their pathways working really well, and they can share their learnings and give you some tips and tricks about how to get up to speed. For the first time, we can now report on clinical frailty. Every time we add a new variable, it does take time for sites to come up to speed. And so it's been quite pleasing, I think, that most hospitals have been able to measure clinical frailty. And this will be a really important tool in terms of research, being able to stratify outcomes via your clinical frailty. And then the last sort of point of interest for me is that something different is happening with anaesthesia. So I'm not an anaesthetist, but it's an interesting pattern. So the mid-blue is general anaesthetic only, the navy is regional anaesthetic only, and the green is a combination. So something is happening here where there's less general anaesthetic only anaesthetic being given. And this will be interesting to look at our next sprint audit. We're hoping to be on anaesthesia, so hopefully it will answer some of these questions. So I'd encourage you all to look at your site's own performance, have a look at the annual reports where you've seen how to find those, share it with your teams, brainstorm, encourage ideas, find out who wants to do a project. There are certainly plenty of research opportunities both at your local site, national data and Trans-Tasman data. And finally, a huge thank you to all of the data collectors. So without your diligence and attention to detail, we wouldn't have this data and reports to be able to share with each other.